Okay, well, good afternoon, everyone. Thank you for joining and thanks for the opportunity to talk to you all today about the work that we're doing. My name is Andrew New, world's worst pitcher, I promise you, and I'm the Chief Executive of the NHS Supply Chain. I think it's pretty important to explain kind of what we are and what we do to start with. So I'll kind of start just very broadly to explain we're a bit of the hidden bit of the health service in England. And we know that our health service is designed around local delivery and local care in a community setting where people can support families, individuals, both preventatively and reactively in their health matters. But there are things that the NHS needs to do to manage its national power as well. And we're one of those bits of the healthcare system that takes a national approach in supporting all of those different healthcare providers in delivering a high quality, resilient service. And that splits into two halves. The first half is a procurement half, so we're responsible for contracting for buying, negotiating, contracting, all the way through life cycle, as you've heard in a number of stages today, for a range of products, and this represents somewhere between 6 and 8 billion a year in spend. All of these teams historically have been organised separately, and they've got autonomy in the way they deliver to ensure the best outcome for the clinician, for the patient, and for the system as a whole. But we're also the logistics provider. So we manage millions of orders, hundreds of thousands of product lines. We stock thousands of items in 7 locations across the UK, and we physically deliver them into a hospital setting and in support of community care and other parts as well. So we cover both the procurement bit of this and the supply chain bit as well. Our model has been in existence in one form or another for 20 odd years. This isn't a new concept of having this kind of quasi-centralised capability to make sure we're leveraging the buying power of the NHS, aligned with a coordinated national logistics capability that's always able to deliver. But the last round of operating model change happened for 2018. And in 2018, the world was a very different place. Priorities were starting to emerge around cost management, priorities around environmental sustainability, priorities around ESG and global supply chains. We've heard of a number of topics that people have presented on today where they've gone further on what's changed in those fields over the last 5 years. And we've got to recognise that too. So we've looked at the factors impacting us as an organisation, and we're in a really challenged place. I mean, the market as a whole has shifted, not just for us, but also for our supply base. We've got over 1,000 suppliers located around the world. We have to understand how to work with them through huge variability in their capability to deliver and our capability to support them in delivering. So we recognise the resilience challenges, we understand the impact that COVID-19 has had, we understand the impacts of different countries taking different approaches, and we've had to become more agile in how we've delivered. We understand that health globally is a massive and growing priority. It's not just our example of how healthcare is changing, how it's developing, how technology is taking us forward, and how the opportunity is huge. But we're seeing the same things when we talk to our colleagues all around the world, both in public and private health systems. There's a recognition of that world is moving on, and we need to move on with it. We know that as we came into this year, the sustainability agenda is huge. The National Health Service in England has said we will get to net zero for 2040, and we play a massive part in that. And actually, we've been working on that area for a number of years, but it's time to accelerate and give more focus in not just issues around sustainability for the environment, but also in making sure we've got good ESG measures in place, great visibility across the supply chain that will really drive performance into the future. And then finally, we've got the economic performance. We recognise that the health service in England is a significant part of what UK PLC does. We look after people, and we can contribute in a massive way to making that as efficient as it possibly can be. And actually, if we don't, we're holding it back. So we've got a job to do to take a step forward and really help and support the system as a whole to be the best it can be. So what are the areas we're going to prioritise in the next couple of years? Well, these messages have come through in one way or another in a number of conversations that I've been in today already. And we've talked about when you design an operating model, how do you make sure that your procurement and supply chain organisations are best fitted within the business as a whole? Well, the NHS supply chain as a business is part of a far broader healthcare system. And we need to look at ourselves from the outside, from the eyes of those people who work with us, collaborate with us and use the service, and say, how do we design those competencies and capabilities in the best way to fulfill their needs? And without doubt, those needs have changed based on everything I've said already. So we're engaging more. On the procurement side, this is about having conversations about what is that real fundamental need that's trying to be fulfilled. We're understanding the operational footprint. How do we make sure our last mile delivery is supporting all of the different use cases for the NHS's supply chain, not just the big acute settings and things that go into hospitals? So how do we vary our capability to better assist the system in being the best it can possibly be? And that means everything in that infrastructure needs challenging. The norms of previous years have gone by, and we need to look at ourselves and say, actually, how do we make the best of that infrastructure going forward? We know resilience is a challenge and will continue to be a challenge. We know that globally, we don't expect suddenly for someone to fire the silver bullet and everything goes back to the way it was. I think actually we've got to start designing our organisations and our supply chains for just a new norm where flexibility and adaptability and responsiveness are core principles of what we're going to have in the future. And that takes a different mindset. It means rather than just designing your supply chain to achieve quality, clinical quality in our case, cost, affordability, and availability of product in the way we thought it needed to be historically, but it also means we need to design it for resilience in traditional ways, where should stock be held within systems. We need to design it with a view on multi-location manufacturing. We need to understand the raw materials that exist and where they come from in the supply. Of course, we have to do those things. But we also have to rebalance our appetite to risk in each of these settings. And for critical components that go into caring for people, we're aspiring to that. How do we make sure they're always available? How do we make a move from we do our best to this is a core part of what we do? And it's a different set of capabilities, different set of skills that we need in the system. And that means we need to talk to our people. We need to understand which different roles we need, which different skills we need to deliver. It means that you can't run a system based on competition with your suppliers all the time. I think this is pretty fundamental. We've been through a process for a long time where you tender stuff a lot, you pick a supplier, and then you buy stuff from them and you deliver it. We've got to be far more collaborative, far more open and transparent across the system. We need to ensure that our consumer base that sit in trusts and in care systems, and they're calling on products for us to ensure are available, we've also provided the same level of collaboration into the suppliers, and we join this network together. And we get that end-to-end visibility, end-to-end performance management, and we can make integrated decisions that are for the benefit of everyone, because only through that collaboration will we really make a difference in the way this works. Digitisation, and we've heard earlier on how to make sure your digitisation projects aren't the worst thing you do. We have to make massive progress. Visibility, actually, across the performance of the supply chain has been relatively low. We've made a lot of assumptions historically around suppliers who've said, yeah, of course we've got those products available, of course we can deliver, we'll always be able to deliver. Actually, reality says that's not always the case. So how do we get some of those leading indicators that help us to give them advice on what they can do differently? How do we bring some of our capabilities to bear with them through that collaboration in future? But we know we've got to modernise our infrastructure as well, and actually we're going to better take a massive step forward. So rather than other parts that have invested sequentially over the last few years and have gradually moved forward, we're going to be able to see a jump. And we're looking to step change our capabilities to better integrate that system together in a far, far better way. And then the final point on innovation, because all of the rest of that stuff kind of says we need to get better at the things we do. Actually, there's a challenge. It says, do we do all the things that we should do? And that's both in terms of our own capability set. Is having 7 warehouses and moving trucks around the country and doing all the things we do around planning the right thing to do or not? Is there a completely different way of delivering some of these things now that wasn't available to us 5 years ago or 10 years ago? How do we make sure that the products that we're buying is not just, can we get a slightly cheaper version or a slightly higher quality version of the thing we've always bought, but how do we enable our clinicians to deliver care using the right range of products for modern environments now? And how do we make sure we've got a faster time from the idea generation through implementation? And they're really important things we've got to develop, we've got to be better at. Because if we do, it's really valuable. And actually, we know that our biggest differentiating factor will be about simplifying the way that the supply chain works and simplifying the way the health service works, not just buying the same thing for less money. And we know that by freeing up time for those clinicians to look after people, which is what fundamentally they all asked to do, we can really help the NHS to overcome a range of its problems around workforce, around capacity, around infrastructure. Actually, we can do that. And we can empower great procurement people and great supply chain people to have a bigger impact and bigger influence across the system. We know that all the money that we release just gets given back to the front line to be able to deliver more care. So as we do get better, we know it enables the system as that geared system to drive faster forward and find innovative care pathways, look after different illnesses, and to better care for people better than it does already. For the supplier side, we're very much focused on trying to simplify this. It has been very, very hard, I think, for a long time for suppliers to truly work with the NHS on a national basis. Even ourselves, we do treat our regional centres as broadly separate centres for deliveries to come through. So the physical infrastructure is even designed around separation of this regional model. And actually, if we're nationally managing these categories and portfolios of products to the best that we can, we should be able to be more innovative in our approach to physically working across the supply base. We should be able to make their cost to serve lower. We should be able to help them mitigate inflationary pressures. We should be able to collaborate more on what matters to all of us in the future. I want to make sure there's plenty of time for questions, but I just want to kind of remind everyone kind of why we do this. Now, this is a health service that we've all aligned behind a set of strategies of things we want to do differently and how we can drive our performance forward. But finding a sense of purpose across the organisation is incredibly easy. Every member of our team joined because they felt they could make a difference. They felt like their friends, their families themselves at some point will need a health service. And what better way can we help the NHS be better than take our expertise and use it to drive the system forward? So for me, this actually comes down to a people thing. I've talked about we want to do some stuff around infrastructure, that's great. We need to do some stuff around the way we work, that's great. We need to do some technology things, that's brilliant. We need to work with suppliers, yeah, we understand all those things. But every single one of those says we need to work with our people, we need to empower them to make the decisions they're skilled to make, we need to train and develop them to be the best version of them they can possibly be in our workplace, and we need to get them all contributing to the best they possibly can and to the system as a whole. So we are at the early part of what I've hugely tried not to use the word journey for, but we're at the early part of that process where we've said we know now what we want to be, we know how to get there, and we know what the next 12 months, next 36 months will look like in the changes we need to make to our organisation. And we recognise the benefit that can generate for the entirety of the system. I'm now in the very impatient phase of saying, that's great, can I have it tomorrow, please? But I've recognised the teams have got to have a chance to deliver some of these things. But there's an opportunity for us now, over the next 12, 36, and then the next 60 months, to really demonstrate what an outstanding procurement and supply chain organisation can do as part of a hugely complicated system that everyone values. So I want to give the opportunity for any questions, either here or online.
Thank you very much, Andy. Do we have any questions from the floor?
I'll ask a very quick question. So, how does... Can you just wait until you get the microphone there? If you could introduce yourself and your company, please.
Okay. Hi, can you hear me? Hi, my name's Neil. I'm from Sky, Operations Manager. So it's about change and how NHS does change and how do you go about it. So, for example, simplifying data processes. How do you go from something that's really complex to something really simple? How do you align your suppliers? How does the NHS go about that in a change project and a change programme?
Okay, so change is a really important part of what we do, and I think we recognise across the organisation that no part of it will be the same in 2 years' time as it was 2 years ago. So we've started to have a conversation both within the NHS supply chain and within the broader NHS about the fact that change should become normal for us. So we're looking at building this core skill set across the entirety of the organisation. So we've got a number of teams that work on small changes. So they've got lean methodologies, they've got operational excellence type approaches, and that's propagating the message across the team that change is a good thing, and that's an important message to get out. We've then got a project management and PMO capability that looks at the major changes we operate and coordinates across multiple parts of the system. Now, some changes, if they involve multiple parties, clearly become more and more complicated. There's more interdependencies. So having really clear scopes, having really clear responsibilities, engaging early and explaining the benefits of what we're trying to achieve. In our world, making sure that all the parties involved have got the finances aligned to make sure they can all collectively deliver, and then having the right people involved in governance and getting the eyes across the project to the right. But I think that's the same in any organisation. I think the principles of good project management, good program management are pretty universal in what we do. We have some extra steps. If you want to change a care pathway, you want to change a clinical device for some reason, there's clearly a whole host of governance and regulation that goes around it, but it's pretty well prescribed. And actually, so long as the teams have the core skills around project and program management, they can execute in a way you kind of expect them to. But the system's quite complicated, but it's complicated because we want it to be the best it can be, and to be at its best, it can't be super simple. Internally in the organisation, slightly different. We have an absolutely ruthless focus on simplifying everything we do. The organisation has changed over the last 20 years, and you've just had layers built on top of layers on top of layers. And there are things we do now that we're not really sure why we do them, but we know we've always done them. So there is an absolute focus in the team now to say, how do we make ourselves as efficient as possible? Because that efficiency will enable us to be as effective as we want to be in supporting the rest of the NHS. So when it's just us, it's an absolute focus. It's one of our objectives as an organisation. Thank you.
Do we have any more questions from the floor? Over here. Thank you very much. If you could just introduce yourself and your company. Thank you.
Thank you. Do I understand?
Stand, sit, whichever you're most comfortable with.
Hello, my name is Lulu. I'm from Estée Lauder Companies. It's very interesting to see about NHS, the change of how you tendering with your more collaboration with suppliers. Could you give us an example of how you have managed the supplier collaboration in a different way from your past, basically?
Yeah,
thank you.
In NHS space, we have this thing they call kind of value-based procurement. And I've said to a number of people before, I don't like the name because value's in the eye of the beholder in this one, and it's about redefining value. And it's that principle of redefining value that's really important. Historically, the decision criteria around tenders and around relationships was relatively simple. It's a reasonably traditional model. We've extended that now to look at upcoming innovative future products. And we've included that now to look at the total life cycle cost of use for products. It's not something that will happen overnight because we're targeting that approach very specifically to the major implantable items, things that have massive benefits to patient care. And there's a supplier who manufactures in Ireland who have developed a new product with us that fundamentally changes the care pathway and the approach to invasive surgery for a certain disease. That opportunity has freed up significant amounts of clinical time, significant amount of surgical time, and the facilities are now used barely at all for that procedure. The actual product is more expensive, but the patient outcome is better, and the efficiency gain in the total system is far greater than the cost of the product in the first place. But we can only do that by talking to suppliers and explain where the gaps are. And I think historically still, we're having conversations with suppliers who've said, we've developed this product, would you use it? Rather than us going to them to say, actually, we've talked to the clinical experts. If you could find a cardiology device that did this thing, there's a real value to that. And that's the next phase of how we turn this on its head and then drive it forward even harder. Thank you.
Thank you very much, Andrew. Do we have any more questions on the floor? Well, I actually have a question that's come in remotely for you here, Andrew. Somebody's making the point that supply in any sector is very challenging at the moment, but within a healthcare environment, particularly a public service healthcare environment, it must be even more complex. And this person is asking you, how do you prioritise what it is you need to do in such a complex and highly challenging environment?
No, that's a great question. So we have around 600,000 products that are available to the NHS Trust to buy and consume in patient care. Of those, there are a number that are very highly clinically preferenced items, things that would actually change the care pathway for a patient, or would mean that some of the clinicians would need to behave in a different way to use a different set of tools to deliver the same patient outcome. And it gets back to that efficiency thing. if we've got a product that's identified as being less available, and we go through a process of managing demand across the system and then managing supply into the system while we recover with that supplier their capability to manufacture, we have to consider what's the operational impact going to be. Because actually the shortage of the product might cost us money to expedite and all things in the way you would expect to from a supply chain perspective. But actually asking a clinician to behave differently and undertaking surgery with a patient is something we never want to have to do. So we stratify our products based on that clinical preference and the impact it would have on a clinician in delivering care to a patient and the outcome that the patient will get. And they go down a scale, down to the reams of paper at one end that say, okay, we've got interchangeability, interoperability, and then we've got less preferenced items where actually if there's no other product available, of course we'd be happy to use that product, all the way up to actually that would need retraining of an expert. And they're the ones that will cause real problems in the system. And we've got alternative matching, obviously up and down where it's appropriate.
And is this a system you have, or are these human decisions?
It's a mixture. So it's a systemically stored data in a broadly well-structured way. I think we're still learning how to structure our data in the most useful way. But we have clinical experts who work with us, who understand the products and their applications in hospital settings. And we also have user groups in hospitals that are able to say to us, actually, that's the one that will be the problem. And there's regular communication and engagement between those teams to prioritise what those challenges could mean to us.
I have another sorry, any more questions? I have an interesting question here from one of our many remote viewers. Somebody's making the point that on the clinical side, the NHS is finding it difficult to recruit staff. Mm-hmm. Is this being reflected on the supply chain side?
I think we're at the point now where competing for staff is something that will be unaffordable for us. In reality, we're never going to suddenly be an above average payer, and we're never going to be able to come and compete with private industry for talent. But what we can compete on is that sense of purpose as to why we do it. And normally, if you speak to a candidate who's interested and explain that the decisions you're making directly impact the ability of frontline NHS staff to look after people, and actually it's in all of our interest to look after it, that sense of purpose tends to help. I am worried in the longer term that premium we get through that purpose may end up not being enough. But that's up to the management team, that's up to the executive team, and that's up to all of our colleagues to explain, actually, we're doing something special here. We're going to make a massive difference. It's a really fulfilling career to be part of. We offer all sorts of training and development and learning opportunities for teams. And therefore, actually, this is a great place to work and to be really successful and with an amazing sense of purpose. But we've got to do a whole lot more in advertising ourselves now to candidates than we'd had previously.
Thank you. And somebody's picked up on the point you made earlier on about simplifying your processes. Mm-hmm. They're asking, how is it possible to simplify something like supply chain when you're working within a notoriously complex organisation like the NHS?
It does make it very challenging because we know we can never afford to have a day out. We deliver every day to a care setting, and that delivery goes into caring for a patient. The idea of saying, okay, we're going to stop everything happening in a warehouse for 6 weeks and we're going to modernise the way it works isn't a real one. So things do take a level of time and do take very sophisticated planning. We test all of our ideas around change management against what could that operational impact be. How do we make sure continuity of supply comes as number one, and then how does the opportunity then order the projects that we should deliver. Fundamentally, there are times when we have to make the decision to say this is such a step change for us that it makes a massive difference, we're going to go and do it. So we're just in the process now of fitting out and opening a new distribution centre in the northwest. At the same time, we're modernising all of the technology that goes in it. It gives us an opportunity to create some additional capacity within the system. That gives us choices as to how we manage our transport management, and it should free up capacity in other sites. And it gives us the ability to kind of knock the first domino over and see it cascade across the rest of the estate. But it's not as fast as we'd like it to, but we always have to work on that risk appetite of we will never be the reason that something doesn't get delivered.
And I'd be curious to know, actually, how the pandemic has changed how you approach supply chain. I mean, we all saw what happened around PPE at the outset of the pandemic, and the race to, furnish health providers with what they needed on that front. But operationally, how has the pandemic changed what you do?
I think the principle that we're adopting is, one, we've changed what we perceived as the most likely scenarios that we test, and now we test probably a broader range of what could happen and than ever been tested before. I think we are now designing supply bases through our contracting now that create the resilience that we expect that we may need in one of those scenarios in the future. But we're trying to manage that without paying additional premium for it, because clearly all funds that are available we want to push towards frontline care and not just mitigation of potential risk. And it's managing that balance. Operationally, it's actually forged some great relationships across the system, where previously there wasn't a need for someone in a trust to necessarily engage with the centre. Suddenly, actually, there's a conversation, there's a dialogue, and there's learning that's going on, and we understand far more now what the impacts are on frontline care of the things that do happen across the breadth of the supply chain. So I think that the biggest win that we've had is that breaking down of barriers, creating a strong network, and then communicating really effectively about what's really, really important to look after people.
And you mentioned, Andrew, that you're operating in a highly regulated environment. What challenges does that present you with that supply chain managers working in other sectors might not have to face?
That's interesting. So we operate in a regulated environment, but we operate in a very, very transparent regulatory framework. So sometimes change management activities, particularly in physical infrastructure, need licensing arrangements from the MHRA as our regulator, and they're very collaborative, working with us on driving that performance forward, and we see them as a very helpful regulator. I think there are issues that we have around the supply of goods, in that because of the desire to ensure that recall management is always there, particularly on patient safety, we have a set of obligations around tracking and tracing products that other industries probably wouldn't. And it's quite easy actually to look at the NHS supply chain from the outside and say, well, you know, it's a number of big sheds full of stuff. It's not a major problem, is it? Anyone could do that. Actually, the processes that we need to follow to ensure that we give that transparency, visibility, traceability of the things that we deliver can be quite onerous at times. And I think we do have a culture shock when people join from the outside and just think, well, it's okay, you just pick it, pack it, and move it. And actually, in reality, there's far more to us in what we do.
And, you know, people probably recognise that two of the biggest political footballs would be education and health. Mm-hmm. What impact does that have on you when you have governmental change, policy change? Does that filter down to what you do in supply chain?
I think we always need to, it gets back to my conversation about operating model. The external environment that we work within changes from time to time for all sorts of different reasons. And it's our job to make sure that we're playing our role in the system as a whole in delivering what that external environment needs. And if that's around gaining productivity in certain skill sets, that's where we drive our innovation with the supply base. If that's around reducing costs, that's what we will therefore focus on what we do. So we need to be more agile in responding to whatever the changes are externally, whether political or otherwise.
Okay, that's great. Well, Andrew, thank you so much for your time.
Thank you very much.
It's really interesting.
Thank you all.
And that is actually the end of our programme of keynotes and forums on the supply chain stage. We'll be back tomorrow. The procurement stage downstairs is still running events up until 4 o'clock, I believe. So please do take a look down there. And thank you very much. Thank you, Andy. Sorry about the introduction.